Why, thank you. Well, yeah, so I am not Ronaldo Wilson, but I am delighted to be with you all today. And I'm more delighted to be able to facilitate a panel with three amazing colleagues. So if I can call up Dr. Feng, Dr. Cajigas, and Dr. Gamata, that would be wonderful. We have three neuropsychologists who are going to be dialoguing with me around how we communicate effectively with diverse communities around brain health and early detection. And we've learned so much and have had such insightful perspectives during the conference today. But what we really need to be thinking about is how to bridge this to our communities of color, and hopefully we will gain a lot of insights and some concrete tips and tricks and effective communication strategies. So I think I'll have our panelists come up. So as I said, we've had so many rich and insightful presentations and panels today on early detection. And what I'd like to do is learn from the three of you, because we have three wonderful experts, on how we take these learnings to our diverse communities. I know this is something at Alzheimer's Los Angeles. It's part of our mission is to work with lower income communities, with communities of color. Thank you very much. Okay. And so I want to start off by asking, why are conversations around brain health and early detection so important, particularly with communities of color? Would anyone like to start? Dr. Gamata?
I'll start us off. I think it'll be a rich conversation for all of us in talking about, early detection and health and why the importance in diverse communities. I think we heard from an amazing panel earlier and just the barriers that everyone navigates, right? And when we talk about diverse communities, it's all of us. We're all diverse. And there are the work of diversity is more challenging and more difficult than we give it credit for most of the time. And we have to reorient the conversation to what is the importance of diversity and why diversity, right? And moving that beyond the moral argument of it's the right thing to do, but rather that it's the real scientific rigor. If you include everyone, what you find is the truth. If you don't include everyone, what you find is bias. And clinically, that you are serving everyone in the population. And so I think the focus, I think, for our panel in focusing on communities that have disadvantages and so forth is really important because we live in a system, we live in a society, and what puts folks at risk are those societal disadvantages. And we can also call those traumas, right? As clinicians, we call those traumas. And as we focus on the concentration of who has more of those social disadvantages, they're concentrated differently in different populations. So while we all have traumas, right, as humans on planet Earth, the concentration of that trauma is different in different demographic groups. And so our attention to who is at more risk for certain disease populations and so forth centers that when we're talking about the general population. But I'm just tagging in.
No, thank you for laying that foundation, giving us some context to propel the conversation forward. Dr. Cajigas?
I would add that, the onus really is on us as providers. I'm from UCLA. I apologize for not being accessible. But accessibility, I think, is a huge piece of this. And the onus is on us. People always expect, I work predominantly with the Latino, Latina, Latinx population. En español, bilingual, yes? So muchas gracias, thank you for having us here. Representation matters, and so having doctors that speak the language, that know the culture, that have had similar life struggles. In extended families, Latina families, you know, we all know someone that has something, right? And that's probably the same in every family. And so I think the onus being on us to create models of care that are accessible, that not just accessible, but that are welcoming. You know, we have a center and a clinic where we do evaluations in Espanol and for bilinguals, Latinos in English or in Spanish. And if you build it, they will come. Yes? If you extend yourself and you put the onus on yourself as a scientist, as an educator, as an advocate, as a clinician, I think that's a huge piece. Because there are so many systems, as Dr. Camara was alluding to, that are working against people. And so we have to meet that with an intentional stance, that we are being anti-racist, we are addressing the issues that we already know are there. And that's for every provider, for every organization. It can't just be at the individual level, it has to be at a more organizational, systemic level as well.
I think what you both said is so beautiful and very similar to what I have been thinking and I wanted to say as well. And so thank you for saying that. You know, thinking about different cultural populations, you know, even if you say like an Asian population, what is that, right? It's like 50 different subpopulations, 100+ languages. I mean, there's no way to really categorize it. Some kind of convenience, but whose convenience, right? So I think, you know, what is it at the core is how do we think about people and patients as people? And how do we think of ourselves, providers, in that same way too? And we have our own biases, and how can we check that instead of just like, what can we do for them, what can we do for us, so that we can really connect. And so there's a humanizing quality to this that is super important. Understanding that we're in a system that is also medicalized. And so how do we balance that is I think, a tricky piece.
So I want to ask you specifically about brain health and early detection. What is unique in different communities? Is that better? Oh, I'm sorry. Okay. So my question is, when we talk about specifically brain health, and I'm curious to know from all of you, do you think that conversations around brain health are an entry point to talk about early detection, especially in diverse communities? So I guess that's one question that I have. And then my other question is, what is particularly unique in diverse communities when it comes to early detection?
I can start us off.
Please.
I think that if you tie brain health to people's everyday lives, right? In our Latinx community, if you tell folks your brain health is going to affect the overall health and well-being of your familia, and that's the way in, you know, whether it's abuelita, abuelito, on the spectrum that we're talking about here. But Alzheimer's and dementia affects us all. And so if we show the relevance and the connection, I think the rest comes naturally. People will be invested and people will want to know more. As I said before, the onus is on us to make this dialogue, this discourse accessible and to connect it to people's everyday experience. You know, a lot of Latina families are caring for someone that may have early stage Alzheimer's, mild cognitive impairment, et cetera, and kids at the same time, right? That sort of sandwich effect is very normative in the population that I serve. And so I think breaking the ice and starting the conversation and just making sure that there is a sense of the relevance, once that connection is made, people will not leave you. They'll want, well, what can I do? What can we eat? What do we have to do? What, you know, it will all change.
It'll open up.
It'll open up.
What a powerful community asset, right? Being part of the family unit and, right, being able to leverage that as an asset, because we talk a lot when we talk about communities of color and Alzheimer's, we talk about a lot of barriers, but it's nice to be thinking about some of the assets that our different communities have and how we can harness those.
If we empower, I would say Latinas, they're the ones that do all the work, Yes, I'm the first one to say, and mucho respeto, much respect, like promotoras in the health system here in the county, you know, if we help to empower people with information that is going to help their communities, then we all get to partner together. And I think we start making a dent.
I would say also just understanding family dynamics in general. So this is like for all people. We exist in a community, and communities are like in your family and in, you know, local community and all of that. So thinking about that piece when you're talking to somebody who may not have the same experience as you, you can at least come from a stance of like, okay, tell me what your experience is with dementia in the family, just as like an example. I mean, this is not speaking exactly to your question, but this idea of like opening up a conversation that is relevant to that person, like you were saying, and that in itself kind of brings you down to understand what that person values, and then you can kind of adapt your conversation from there.
I just want to add on that resiliency is something that was cultivated, right, as adaptive, because it was survival for communities that were at more risk, had more traumas, had a lot more to overcome. And so tapping into community was a part of the survival tactic, right? And so what we see now as you know, oh, they have this unique benefit to them. It was a survival tactic, and it's something that we can capitalize on, because when you think of who's most vulnerable for any disease, right? The person most vulnerable is the person that has no community, right? And so the more that we can build that in building with existing community partners, linking arms to what exists so that we connect the dots for folks. The family first and foremost, but also beyond that, what other community systems are there that can also participate in the care?
There's a saying in Spanish, un dicho, yes, that says, las penas compartidas son menos. When we share our trials and tribulations, they are lighter, they are less. And so that, as Dr. Guevara was saying, is ingrained in a lot of our cultures, the sharing. And it's when we become isolated and separated that we lose access to that resilience point, to that adaptive survival, you know, las ganas, as we would say in Spanish.
So let me ask you then, because we have this resiliency in communities, and as you said, we can garner that and propel that forward, but we also hear a lot about the stigma and shame around Alzheimer's dementia in various communities of color. And I wonder if you can speak a bit about what is that stigma, what is that shame, where does it come from, why is it there, and for providers, how do we have these conversations in the clinic when we know that there is stigma and shame as well?
It's
Dr. Fang?
Yeah, it's sort of a tricky one. You know, of course there is stigma in mental health, stigma, like, and with Alzheimer's and dementia, the stigma is really difficult because being labeled in general is so hard, especially when there's no cure. And we're, you know, like, we're listening to the primary care assessment and how great it is to have these questions, and also knowing that so many people don't answer yes for years and years and years, even though they may know, but why aren't they answering yes? It may be a knowledge thing, not aware. It also may be like, well, what are you going to do with this information? Where's this going to go? Are you going to tell my partner, this person, that I wrote all of this stuff about them, right? So there's a nuance in it, especially when you're talking about communities, that is not just stigma, but really like the interconnected nature of when you deliver information, what's going to happen to that information, I think is really important to keep in mind. So maybe I'll start it off from that.
Absolutely, absolutely. The stigma is for everyone, right? And then in certain populations, there is just what Dr. Vang was saying, where is this information going? Because with health disparities, we have to come back to the foundation of health disparities, is, medical abuse as well, right? So where is this going? Where is this tying into? Because these all link, right? And for us, our work is to tap into what the history is, because the history comes into the room. The history, we can't do diversity work without bringing in the arc of the history of what has happened, right? It's like doing a medical workup without doing a good, thorough interview. So our work in really building that trust, and that falls on us and not on our patients, to really share the details of why you ask what you ask, and not just asking the questions. I think we have to get better at asking good questions as well. But it's beyond the questions that we ask. It is also laying the foundation of the why behind our questions, so that the family, the patients, everyone in the space that we create feels safe and brave to share the truth of what they're navigating in their home day to day. Unfortunately, there is medical brutality that the communities face, right? And so just knowing that, and when they walk into the room, that you want to set a foundation of like, I know this history, and I want to create a space for you that is centered in your belonging, in your care. And cultivating that is artwork. It is creative work. It's beyond the checklist. It's beyond the efficiency that the system forces, right? And so it's some of the most creative work that we do is cultivating that belonging, that safety, and that authenticity in the care that we give to our patients.
Well said.
I think, yeah, very well said. The construct of stigma is one that really fascinates me, because when we think of stigma, most people think of it as residing within an individual or within a community. Mm. Oh, this is something that exists within a minoritized community. And even the term minoritized shows you it's from the outside going in. So I think it's less about stigma inside the person and more about how we stigmatize, right? And so we have to be the ones the onus is on us to meet people where they are and to create that safe, brave space where people can speak up. And feel comfortable and normalize the dialogue and the conversation that needs to happen. Because otherwise, when we talk about stigma in communities of color or minoritized communities, we're blaming them. When we're creating an us and a them, we're othering. And it doesn't reside within. It's something that is done. It is stigmatizing. So we have to be anti-stigmatizing. Yes. One thing, I'll give just a very brief example. Alzheimer's disease, common symptom anosognosia, right? The person doesn't know that they're losing the memory or that they're developing certain symptoms. So how do you talk about that in the presence of a patient? With our Latino patients, I use la araña. Yes, an araña is a spider. And I say, imagine that I have a spider on my back. And you say, doctor, you've got a spider on your back. And I turn and I say, where? Where? Oh, it's crawling up your neck. Where? I can't see it. Right? I say to people, there will be some things that you yourself won't be able to see. But there will be some things that we cannot see unless you talk about them, unless you bring them out. And so let's just accept that there may be differences of opinion, and you may see different things. Your loved ones may see things that you don't see, like that spider on the back of my neck. But there may also be things inside of you that we won't really learn about unless you open up and talk about it. And so the power, I think what I'm trying to say is the power of metaphor and storytelling, cuento and dicho in Spanish, is incredibly powerful in breaking down stigmatizing encounters clinically.
I love that example. I just piggyback off it. I feel like using this and knowing your patients well enough to know what bit is going to resonate with them. That is a real skill. But I think we all have that skill, and so it doesn't take hours and hours. Sometimes when you know that person, and of course there's a consistency there, they come back. It's those like two things you go back to. And it gives people permission to be able to share something, and allows that care partner also to potentially say something, to say, well, your partner, may say things or may be able to, but it's all in the best interest of sharing. Yeah.
Definitely sounds like part of what we're talking about is that relationship building, right? And being able to connect with people, understand them, and give them that space to do so. How do you reconcile that as providers with your, the cognitive health assessment should take you about 5 minutes to complete? Doesn't seem like a lot of time and a lot of space to encourage those opportunities for bravery and discourse and dialogue. So how do you balance that?
I think that there are certain clinical heuristics that you can use. I hold my patients' hands. I hold their hand because I want them to lead me towards certain things, and I want to be able to lead them towards certain things, and I want to establish that connection. As Latino, I was raised pinching my cheeks and touching, abrazos, very demonstrative, right, within the culture. And there's variability in every culture with regard to that. But what I'm getting at is sometimes it's that little cultural door or know-how of knowing how to open it. I use dichos all of the time, sayings. No hay mal que por bien no venga. There's no bad that doesn't come about for a greater good. We're going to get through this together. Okay? That little touchstone with the culture will put a person at ease. I use humor, right? I talk about la secuela. La secuela. And people say, secuela? Like sequelae? No, secuela juventud. That youth left us, right? That's what we're here to talk about, right? These are the things that come, and people laugh and you build a rapport. Basic clinical skills. Building rapport and a sense of we are shoulder to shoulder, facing this together. I am with you. You are not alone. These are all things that every patient wants to hear. But we don't do enough of that because we feel uncomfortable. That's why the onus is on us. These are difficult conversations.
Yeah, absolutely. I will say, as a neuropsychologist, we're very privileged in the amount of time that we can have with patients. So it's a very different world in that sense. And we even have conversations before they come to see us. So there's a little bit of you have this appointment. I just want to orient you on what this appointment is going to take. And so a lot of the things that were coming up that Greg was sharing and that Sandy was sharing, that Dave was sharing, of just like the disorienting piece of like walking in and being just asked all these questions and then having all these follow-ups and so forth. We don't have that, but that's as a specialty in neuropsychology, right? And so for those that do have that limited amount of time, some things that I've heard have been beneficial and helpful is the person that the point of contact before, whether that's the administrator, admin staff, and so forth, that person gives a little bit more of an orientation of what that workup day might look like. And so that's just at the level of orientation, right? So I think we're always nervous going into any appointment, doctor or not. Any appointment is like, what's going to happen? So just at the orientation piece, having someone orient you ahead of time, the day before the appointment, just helps alleviate some of the anxiety about the process and what all is going to happen. Should I fast? Like, we do brain health work, but we have patients that think they're going to have blood work done. So that I didn't eat or take my medication. I'm like, whoa, let's do that before we start anything. Because that's what they're used to when they go to doctor's appointments.
I love that. Thank you for sharing that. So I'm a geropsychologist, so I've done some neuropsych work, but really I speak to clients in therapy. And so in the same way, usually I have a bit more time. And so it speaks to this idea of like every provider in that person's journey has a place. And so what is the responsibility, or what can you do in your one connection with that person? And as a geropsychologist, primary care is huge. I mean, like, I don't get people that usually self-refer, right? So it's having that really great communication with PCPs. And so just like that initial rapport building, because a lot of people, when they have that great relationship, they trust their PCP so much. And they keep coming back, and they'll ask like random questions here and there. But to have a trusted person, to be able to say, hey, go to this person, and then tell me how it went. Or that person's going to connect with me. I mean, this is a whole interoperability thing that is another conversation, but there's a time and place for these different pieces. So even practically, without that time, there are also times where patients are sitting in the waiting room. And so I don't know about you, but when I'm sitting in the waiting room, there's things on the wall that I'm looking at, and I'm like forced to read it because I don't have anything else to do. So is there something you can put on there that maybe they won't ask you that first time, but the next time they come in, they may say, oh, like, it's something to like bounce off of or to use to have that start that conversation.
So what are your tips? What are your tricks, especially for providers that may not be from the same community? Maybe they don't speak a particular language, so they don't have the ability to use the common stories or los dichos, that as much as they may try, I think I studied in Mexico, I speak Spanish, but that level of like what you're talking about, the storytelling, los dichos, I'm not sure that I could do that, right?
That's okay.
And I'd imagine for some of our providers, like, we are who we are, and we can try to learn about other cultures and ethnic groups and languages, but the reality is there's certain differences that we all have.
I think it speaks to the parallel journey of helping the providers that we already have and being committed to create a more diverse provider workforce. I really think that we need to think systemically rather than individually, because we end by saying, well, what can we do for the providers? We privilege the providers. What patients need, I think, and families, is doctors that look like them, that speak their language, that are members of the culture, especially in a place like Los Angeles, between Asian, broadly defined, like Latino, broadly defined, right? African American, 75% of Los Angeles, it's only 26% or so that is non-Hispanic white. And yet look at the doctors, right? So yes, it's important to give tips and everything to individual providers that we have now, but I think equally important, if not more so, is that we really commit to advocating for a more diverse workforce. And it can be interdisciplinary. I'm thinking, I'll plug on the UCLA side. When I saw the couple up here, I said, oh God, I wish they would have been part of our Alzheimer's and dementia care program. Because when someone gets a diagnosis, they become eligible for this program, and all of a sudden there's a multidisciplinary team that addresses every little facet and thing that they need, from caregivers to estate legal planning to a whole host of things. I think we need to think about systems and pathways. Because there's too much of an onus on individual clinicians. We need to create community among providers so that they have, like you said, I think, a go-to person that they can rely on that will be able to help the person in the next step of the journey.
Absolutely. I think I'll just add on that, if you, as a provider of someone that is not oriented to a person's culture, the first and foremost thing you do is listen. Like, that we need to listen well. I think was that Greg or Dave? One of them literally said that. No, Greg said it. Dave said it, and he said, if I can remember verbatim, he said, one thing I wish that they would have done is I wish they would have slowed down and listened. Just slow it down and listen and process, right? Again, it's the timepiece, and that's why we always come back to that this is a systemic issue, right? That we have a 15-minute visit and it's like in and out. But the biggest part, if you're talking for 15 minutes and got nothing, your patient didn't feel heard, didn't feel understood, that 15-minute was completely wasted, right? And so if it's that you spend 12 minutes listening and you got 3 minutes to sum it all up and wrap up the clinical visit, at least you heard something. You can follow up on certain points at the next visit, but that there was some takeaway rather than this rushed but no result piece. So it's like walking into systems of checkboxes doesn't allow for any relationship building. And so if we can allocate more of that time to the relationship building, we can get to the checkboxes, because then you can actually do all the checkbox thingies outside of the clinic, outside of the 15 minutes. Yeah.
And have it be meaningful.
Right. And did I hear you correctly? That's one thing I always, language is really, really important to me in your clinical care. So I'm just going to rephrase what I think I heard you say. Does that land correct for you, or did I get that completely wrong? And of course, creating that safe and brave space is, I want them to feel brave enough to say, no, actually, doc, you got that wrong. That's not what I said. But like, if you don't do that bounce back, you can have them completely wrong in the chart because of a cultural misunderstanding at the foundation of the visit.
Yeah, I would just add one thing to it, which is doing our own work on ourselves, because there's the patient, and we focus so much on the patient, but it's again a relationship, and we impose into the space as well, and often we don't recognize how it comes off if we're not really spending the time to think about it. And there's so much complexity to us as a human, and for minority population, like, so we were talking about like immigrants, and so it's like, well, the generation that came as immigrated here, and the first generation, that dynamic is very different. And so, thinking about the care partner, the person that comes in, is it the adult child who's the first gen, or are you speaking to a fourth generation Japanese American woman who's like, it's so different. And so, it's very complex, and it's hard to get in a small amount of time. But if you work on yourself, if we work on ourselves, it makes things a bit clearer and kind of opens up conversation.
Yeah. I think that's so important. The looking at yourself and making a commitment to say, I'm going to learn something about the population that I'm serving. Right? If you're in Los Angeles and you don't know very much about Mexican culture specifically, I would say you're probably somewhat negligent as a provider, just by the numbers. Right? So if we all commit to being, I say, Jack or Jill of all trades and master of one, increasing our through cultural humility, trying to increase a little bit more know-how, a little bit more understanding, that'll go a really long way. But it requires effort, it requires care, and it requires that humanistic, seeing the person, the people that come to you as human beings.
I'm looking at the time. I don't want to dominate too much, but I have a question for you specifically, Dr. Feng. You've been involved for a very long time in Alzheimer's Los Angeles' API Dementia Care Network. Oh, I have 10 minutes. I'm not as pressed for time as I thought. I have more time with you than we have to do some of our clinical assessments. The irony of things. So, Dr. Feng, I wanted to...
It's an allocation of time and resources.
Right? Fascinating. I was wondering if you could speak for a minute or two about the Dementia Care Network and the role that it plays within the API community here in Los Angeles, and how it kind of bridges some of the things we're talking about in this conversation.
Yeah, so one of the things that, so I'm a member of the API Dementia Care Network, and what I love about it is that every other month I allocate the time to spend with these other lovely people who are involved in dementia care in some way, but maybe not necessarily a clinician or whatever. And just getting together, you learn so much. Just like people are talking about something else, like what was your favorite movie or something like that, and what was a favorite book, and just allowing for space. I've learned a lot about like the resources, even things like clinical trials, all this information that I would have to seek out, and everybody's really busy, and so it's just like, okay, well, let me just like allocate this time so I know I'm going to learn a lot of good stuff. And that then translates to my clients or to people I'm talking to, or when I go to skilled nursing facilities and I'm just like, you know, there's a lot of word of mouth, and this is its own kind of community in some ways, and so it transfers that way, in addition to like actual like clinical resources that I'm referring somebody to. So that's sort of something that I really have benefited from, which is a personal thing as well. You get to build really good relationships, and from there you know who, you know, I don't know the right person for this, but this person can tell me who I can go to, and you know, should there be better ways to do that instead of going to, yeah, maybe, but that's a whole nother system question. So that's one of the things I really benefited from. Yeah.
Thank you. And you touched on resources, and I'm curious to know, within your experiences, what resources are available to encourage meaningful and effective conversations and kind of break down some of these barriers with community? Do you have any resources for our providers or for our families that you have found particularly beneficial?
For providers, I'm a fan of pointing people to Ethnomed, which is a website that gives brief histories of different cultural groups throughout the world. You know, our own ignorance as providers, I think, is a scary thing. When we're trying to meet people at their most vulnerable and render evidence-based, like, care that actually helps and doesn't harm. That's a simple one. Just to get to begin to know. At least, for example, if you have a patient from El Salvador, you need to know about the violence in El Salvador during certain generations that were exposed and others that weren't exposed as much. If you don't know that going in to an assessment where someone has memory problems, that's, you know, PTSD, flashback, all that stuff, you know, very, very important. So I think resources that way. There's a Cultural Navigator, I think, also an app that is similar to Ethnomed, that is a good starting point for providers. I'm always a little bit reticent because I don't want people to think, oh, if I use that, then I'm good to go. But that's a good starting point.
Resources just generally. So I'm part of the Dementia Care Network with Preacher Niles as well, with Alzheimer's LA, and just the resources that exist within communities, very small nonprofits that really do the boots on the ground work that a lot of the bigger, larger organizations don't really tap into that work of just like the very basic needs. Like I had a caregiver recently who had hip surgery and needed a commode, and insurance was giving her all types of hell, and calls me and, I need a commode. Do you know anyone who's got a commode? I'm like, actually, I do. And I was able to call one of the community providers, like, hey, last time I was there, I did see a room full of commodes. You still got some? And like, we were able to get that to her within 24 hours. But that's like the work of that, knowing where the community is, knowing where the resources are, and that these are things that were cultivated, right? Boots on the ground. These were all donations, people that had use for it at one point that didn't need it no more, that donated it to a particular organization. And so just linking to what exists at the community level, because I think the larger foundations, organizations do really, really good work at the research and policy level, but we need more hands-on, tangible things that caregivers are always in need for, and those exist in very small, tiny nonprofits and organizations, and we need more of a link and a bridge between the larger organizations and those tiny, mom and pops kind of spaces where they saw a need and just said, you know what, I'm doing this. I'm based off of the experience I had, I am building this. And that's where most of them started off, and they really meet the needs of community in ways that others have not tapped into, and that the resources haven't gone into. So I've been really lucky to have found those systems through Petra Niles of Alzheimer's LA, who's really, she's been doing this work for years, and has really the network that she's cultivated in the community of, oh, you know what, you need to call this person for this issue, you need to call this person for, like, that's like a resource you can't put a price tag on.
Absolutely. It's like we can't all be everything.
Right.
So how can we know the people and the systems for the right time and place for that person? Because we all know about data dump and information overload, and there's so much out there. I mean, it's not a lack of information in a lot of ways, right? But it's how can we get that information right to that person, give them what to expect here so that there's hope and there's productivity and makes sense, and move them along. And when you're talking about the community resources and who has this and that, there's like a really positive benefit to those conversations, even the belongingness, the feeling that you're not alone in this. And so it's not just the resource, it's not just the commode, it's the connection with those people as you're building, as you're going through all of this.
We talked about empowering people earlier, right? Caregiver support groups, I think it was mentioned up here. That's where I started. It's ironic, Dr. Alving was a neurologist when I was a research assistant before even graduate school in Fresno with UCSF. And it was there that I learned in caregiver support groups how to live with Alzheimer's disease and how to thrive. I remember sitting at a caregiver group and people talking about the gift of Alzheimer's disease. And I was like, what? The gift? I think caregiver groups are a missed resource, especially when people leave the groups, right? Because they amass all this information, all these connections, all this support and everything. As long as they're within the group, they're able to share it. But then their loved one moves on, right? And they leave the group. And all of that amassed life experience and knowledge doesn't go anywhere. We should have programs that invest in caregivers. Caregivers that, there used to be, I think there's still the California Caregiver Resource Centers, right? But they're not as funded as they used to be. If we invest in caregivers, that's the way, because they've lived it, because they've dealt with the crappy doctors and with everything, and yet we don't see them as a resource and we don't invest in them, which would edify, it would bring meaning to the experience. I've gone through this. Let me share. Let's invest in our caregivers. I think that's a missed resource and one that could really make a difference.
It also helps to normalize being a caregiver in a lot of ways, because we all, what's the percentage? We're all like dealing with this unexpected career, right? And so it's not talked about until like now you're labeled as the caregiver and you're like, wait, but I'm the same person and I've been doing this for years already. So, it's part of life and part of what happens when you love other people and you're connected and you want to care for people. And yeah, it makes just a lot of sense to connect with others who are having the same experience.
That human experience, as we keep talking about. So as we close, I don't know if there are any questions from anyone here. We don't have a ton of time, but we certainly have enough time for 2 people, assuming you don't talk too long. Both people in the audience and our panelists.
Thank you for, where do I put this? Okay, thank you for letting me ask a question. One thing that was occurring to me as you were talking about really understanding your patient's background. I'm really fortunate to actually work with a neuropsychologist who always gives the historical context for our patients. It's totally amazing and really helps. I think especially when you're not from the same background as the patient and you're trying to do a dementia assessment, and I feel like there's a lot of burden on neuropsychology very specifically, and we're trying to reduce the stigmatizing way we're doing it and the way we're, I actually think sometimes it is a just inherently threatening assessment, and that people are very aware that it actually is going to take away independence. Mm-hmm. Yeah, sorry. It's actually going to take away independence and freedom. And these are folks who have been in situations where that's happened to them repeatedly. And so when I have patients who don't want I don't know what to do here, I'm so sorry. When they don't want the assessment, I actually see that as a good sign. Like they're being self-protective, they're advocating for themselves. It makes it really hard to take care of them sometimes or move things forward. But often I do see it being used in frankly, at the end of the day, a way to formally remove some of their independence and power. And I know we don't want to use it that way, and that a lot of times we're not using it that way, but I'm wondering if you have either a language or an approach to help contextualize, especially for people who've been repeatedly abused by the system, how this can help them.
Mm-hmm. Yeah, absolutely. That comes up a lot. Neuropsychology at its foundation has a lot of medical bias and racism sort of baked into the tools that we use, and we've written about it, of just some of the stimuli that we use in neuropsychology as well. And so really, when the patient comes into space, to really say, we're gathering data. We have some tools. Our tools are not going to be definitive. We're going to work together to really get a clear picture, and to really tag in as we're a team, and we're going to build this together, and we're going to see how we can optimize your care. And that, first you're like sharing power in the room, right? Like you're the expert of you're the lived life and all of that. I have some tools here. They're not the best. We're going to use the best ones from the tools that we have here. And I find that when we set it that way, it helps. And when there's a dynamic where the patient doesn't have the awareness, but the family is really concerned about their safety and so forth, I just say, you know what? You don't think there's anything wrong. Your daughter seems to have this concern. We're going to work together. It's nobody's right or wrong, but we're going to work together to see how we can optimize your health going forward. Taking away that dichotomy really helps in alleviating the tension in the room and really trying to get them to come in for the assessment.
I like to tell people that a neuropsych assessment, the tests themselves, are like all the other tests that you get. We're looking for points of convergence, yeah? With the MRI, with the PET scan, with the blood work, with the neuropsych testing tools, right? But the neuropsychologist, the human person, working with them and integrating that information and making sense out of it with them, that's the report. That I think is what helps to lessen the anxiety, the fear, the triggering from prior experiences, all of that. When we meet people as human beings, because our tests are only part of what we do. As neuropsychologists, it's the integration of information, the brain-behavior relationships, and the inferences that we draw. That's our bread and butter, if you will. So I think just helping people to understand what our role is that we're not gatekeepers, but that we're looking for information and to synthesize that with them.
Even having a short conversation with the neuropsychologist you're working with can give you that information, and so that information can be repeated, and so there's a feeling of connection and like, okay, I can expect this, I went here, oh, that's what happened, and then you learn from that. So just those short conversations with other providers, I think, helps a lot.
Okay, if I can have you join me in thanking our panelists for such a rich conversation.